Thank you, Dr. Scott, and welcome everybody. We'll hopefully end on a high note for med management for this last hour, but I'm a family medicine pharmacist, so I practice inpatient but teach outpatient with our family medicine residency at MUSC. I have no disclosures to make. We will talk a few times on off-label indications, but I'll kind of note that when we kind of go through that part of the presentation. These are going to be the three objectives that I hope that you will be able to take from this. Recall three new recommendations from the ACC/AHA guidelines. Those came out middle of last year, but I'm going to focus specifically on antihypertensive drug monitoring and treatments, evaluate drawbacks of various treatment regimens, and then last but not least, adapt antihypertensive regimen for specific patient scenarios. So we're going to have a lot of audience response in this talk where I want you all to shout out answers about how we manage some of these cases. So kind of building on Dr. Woodfield's and Lyon's presentation, we're going to focus in on the truly resistant hypertension cases and specifically focus in on med management, look at some new therapeutic options, and then I have a couple personal pet peeves with medication use in primary care patients. So I've got a few hot takes kind of built within this presentation. So just to kind of orient people, I want people to be familiar with this chart, kind of thinking through the strength and the quality of recommendations from the ACC/AHA guidelines. So we'll note that most things are not in this green or dark blue category, but this would be based upon multiple randomized controlled trials. If it was in the blue category, it'd be a strong recommendation, meaning that the benefit is much greater than the risks. Most of the things that we are going to be dealing with the recommendations from ACC/AHA are focusing on these 2A or 2B, kind of in the yellow or orange range. And then most of them are done based upon randomized controlled trials, but they might not have necessarily been replicated, or a couple of non-randomized trials. So we've got our various blood pressure categories. When are we diagnosing blood pressure? What is our target? What is stage 1, stage 2 blood pressure? The big emphasis that I took away from the new guidelines is a strong push to get to 130/80, particularly in high CV risk individuals. And they really emphasize these three kind of categories: people with a prior event, prior stroke, prior heart attack, people with the chance for CKD progression with chronic kidney disease, and then folks that we are at risk for dementia. These are subgroups that have much more benefit of going to 130/80. So if you look at the chart, I took this snapshot of the guidelines. If you look at the first recommendation here and the third recommendation, these are in high CV risk individuals, and the top is systolic blood pressure goal, 130, and then the diastolic goal is the third line here, and this is where we're getting diastolic blood pressure goal of less than 80. But one thing that they note is if you can get it to 120/80, do that, as long as you're not causing an increased risk of side effects and what have you for your patient. Where I feel like we are working a ton more within primary care, those in folks that might not qualify to be classified as high risk, or we're working with frail elderly patients that we might be needing to have slightly higher goals. So you'll note that in this other category, so lines 2 and 4 in this chart from the goal blood pressures, this is based upon much less evidence. So there's much less evidence for shooting for 130/80 in these populations that don't have as high CV risk, but it's still advocated for in the guidelines. So we'll keep that as kind of like our frame of reference for often where we're trying to shoot. But I think that one thing that I want you all to go away with is make your own plans for individuals and try to have individualized goals for people, because this might not work out for the variety of situations that you are seeing. And then the other big thing that I would emphasize heavy use of PREVENT. The PREVENT score is now recommended within the blood pressure guidelines from ACC/AHA. As noted by Dr. Lyons, you can kind of go on the website for ACC/AHA and pull up the PREVENT score for those that have not seen it. It is a little bit better as far as like actually calculating out cardiovascular risk than the prior ASCVD risk cohort. It adds a couple of things on there that enhance the prediction. It adds chronic kidney disease, it adds BMI, it talks about the level of control of various comorbidities when you look at lipids and diabetes and blood pressure. And then it adds zip code as one of the SDOH type things to think about when you're figuring out somebody's cardiovascular risk. But if you kind of go through this algorithm, if you have an individual that's had a prior event, prior stroke, prior heart attack, automatically it kind of kicks you into the 130/80 goal. In individuals where their PREVENT score is greater than 7.5 for a 10-year risk, that also kind of kicks you into the less than 130/80 score, and they prefer starting medicines as opposed to just starting with lifestyle. If you are having the individuals that has an elevated blood pressure, has a low PREVENT score, this is where they would say 3 to 6 months of lifestyle interventions to optimize their blood pressure before kind of jumping in with a trial of medications. All right, so going to start with this case. You're considering workup for a patient with resistant hypertension. They are a 58-year-old male. They've had a lack of response to medication. What is the most common cause of uncontrolled hypertension? Just shout it out. Medication non-adherence, correct. By far and away the number one. What would be number two? B or OSA. So OSA would be the number two of all the things on here. I took this from a family medicine in-training exam, and they really emphasized the level of non-adherence that is happening, which I found sobering. I looked a little bit into this and tried to tease out what are we working with when we get patients with resistant hypertension, and the rate of non-adherence is between 50 and 68% depending upon the study you look at. So that I think speaks to doubling down, refill counts, figuring out going to pharmacies and figuring out have they actually filled their medication, asking those types of questions. What side effects are you having with this new regimen? You should be having some types of adverse effects potentially. So that would be, I think, the come to God talk that I would try to have with all of your patients is how often are you missing your medicines? One thing that was interesting was there was a nice dichotomy of people that were having non-adherence to various blood pressure regimens. 30% were just completely not taking it at all. And then 70% of the people that were non-adherent had partial adherence, where they were missing doses, but they were still taking a proportion of their medicines. This chart comes straight from the ACC/AHA guidelines. So I think this is a nice thing of people that are having resistant hypertension, the prevalence of some of these various adverse effects. Up to 50% of folks might have OSA, chronic kidney disease, primary aldosteronism is very common. And that's one thing that is heavy emphasis within the ACC/AHA guidelines is to do the workup for primary aldosteronism. I'd note drugs of abuse, substance use disorder with alcohol, another lower percentage, and then renovascular hypertension being a very rare potential number of patients. But I think this is nice to think through when you're just thinking, okay, what do I need to target? When do I need to send people for a sleep study? When do I need to potentially do a screening for some patients with primary aldosteronism? But these are the times to think about a referral. So individuals where you're having blood pressure issues and they're less than 30 age, you think about potential secondary causes, resistant hypertension despite optimization, folks that you might refer for renal denervation, or considering primary aldosteronism that potentially needs subtyping. So these are the times to potentially consider a referral to a hypertension specialist. One thing I will note is we actually do have a hypertension specialist clinic that is starting within the MUSC system, so that might be a place where you can refer individuals to help to figure out what are the potential driving factors for their blood pressure, work it up, and then potentially get them on an appropriate treatment regimen. So these are the things to think about as far as referral. I think Dr. Lyons highlighted this really nicely in the last talk, going through doing an accurate blood pressure. I think of all the times that I've ever had my blood pressure checked in any primary care office, I don't think that it has ever 100% of the time been accurate. So I would say that that is something to definitely think about. Think about your ambulatory blood pressure monitoring. Think about home monitoring. I think that that paired with what you get in office-based blood pressure measurements are important. Things that I would think that I would prioritize, and I try to emphasize this throughout this talk, is use long half-life, use combo pills, try to go with less frequent intervals. Those are a couple of key points that I want you to kind of take away from this, because when you look at the studies, these triple or even quad pills from the research literature is always more effective for adherence and ultimately control. And I think this was nicely outlined too by Dr. Lyons. If you're very far from your goal, more than 20 points over 10 diastolic, go with 2 drugs. That's going to be much, much more effective to get you to goal. If you are close to goal, add a mechanism. Add a different med from a different mechanism of action. Maybe potentially combine it, put it in as a combo pill. And then what I view as when is the appropriate time to increase a dose is if you're really close to your goal. If you're 3 to 5 points, I think this is the time in primary care that I've seen us get hesitant sometimes to go and escalate a regimen. I think that if you are consistently seeing averages, you repeat it in the office, you look at their home blood pressure regimens and they are not at goal and it's just a little bit, still try to work on lifestyle parameters to address it and consider dose titration. Don't get complacent is the thing that I would kind of take away from this. I'll also note a couple of my colleagues at MUSC, we actually wrote the more recent AFP-resistant hypertension article that just got published. We actually did a YouTube video that's on AFP's website for free that you can kind of share with patients. So you actually see me as the patient that is doing all the wrong things when they're getting their blood pressure measured. And I found it pretty sobering when I actually saw what my blood pressure was. So I did all the wrong stuff. I had my feet crossed. I was on the exam table. Dr. Haley, who played the physician, was talking to me about how I was smoking at the swim meets for my kids, and I didn't know about this, and I didn't even know I was a smoker. I got my blood pressure up to 178. 178. So I did all the right stuff. I was still getting videotaped. Did it about 10 minutes later, got a short sleeve shirt, wasn't over clothing, all the right things that we were trying to do. It came down almost 40 points. And I don't have hypertension, thankfully. My blood pressures are usually in the 120 range. But it was sobering to me to kind of go through that whole process of how big of a deal are all the things that we kind of try to do, and it actually makes a giant impact. So that is one thing that I would kind of double down on. Try to do your best in your office practice to figure out ways to actually calm down the patient, repeat it, make sure they're not doing their history when they're getting their blood pressure done by your nurses or your techs kind of doing blood pressure measurements. One thing, too, I'll note, if anybody has a want for any of these slides, I'm happy to email them my slides. You can just find me at Bragg SC at musc.edu, and I'm happy to share this slide deck with people if they have an interest. So this is kind of my stepwise approach, and I think that it often aligns a lot with things that Dr. Lyons was talking about in the last hour. I too have a preference for ARB over ACE, and I almost never recommend an ACE over an ARB when you think about the dry cough, when you think about the angioedema risk on the ACE inhibitors. Usually my first line thing that I recommend is often amlodipine or an ARB often with a long half-life. I personally find fewer compelling reasons to use a thiazide, and I know all the monitoring issues and all the side effects. So I personally tend to use that as a second or third option when I'm making recommendations. Usually when I think about the first two drugs, I try to pick an ARB with a long half-life, and I try to often pair it with amlodipine because there's a lot of great combos there. When thinking about thiazide-like diuretics, I usually kind of save this for third line, HCTZ versus chlorthalidone and indapamide. If you look at the guidelines, there's heavy preference for indapamide chlorthalidone. I don't know that that is definitively necessary because there's a lot of great combos with HCTZ, and we'll talk about some data comparing cardiovascular risk between HCTZ and chlorthalidone. Largely what I do is I look at the baseline potassium, and if it's low, I recommend HCTZ, and if the baseline potassium is really high, I often recommend chlorthalidone. Aldosterone antagonists always should, generally speaking, be your fourth line, unless there is a compelling reason to pick something else. Picking spironolactone, picking eplerenone, picking our newer agent finerenone, very reasonable to consider. Does anybody use amiloride? Has anybody done this in a while? I kind of in PharmD school and even in residency, this wasn't on my radar as a potassium-sparing diuretic. There's a more recent study that I'll show you. There's actually similar results to spironolactone, which I found kind of remarkable. But we'll talk about some of the data there. Similar to our Dr. Woodfield and Lyons, I would really try to save beta blockers for fifth, sixth line unless there's a really compelling indication such as post-MI, recent ACS, patient with heart failure, what have you. One that I too have a love for is diltiazem. I think there are potentially patients that might get some benefit from diltiazem as another kind of later line option, but we'll talk about some of the nuances there. So this was a really nice study. So if you look at a lot of literature comparing ACEs and ARBs, many of the systematic review meta-analysis will say that there's better benefit on ACE inhibitor than ARB, and a lot of that is based upon the baseline studies and where they were done. And I would note that a lot of the ACE inhibitor original studies were in high cardiovascular risk individuals, and then the ARBs, patients had better blood pressure, they had more statins, they had more in a platelet therapy with aspirin. This was a more recent study. This was done by the Mayo Clinic in 2016, and they controlled for some of those baseline risk factors and actually showed similar outcomes. So this was a nice thing for me to see, and they also highlighted decreased dry cough, decreased risk of angioedema. So it had, at the time, really steered me into saying, hey, I'd only, generally speaking, recommend an ARB kind of first line. The other couple interesting studies, which thiazide to prefer. So I kind of used to be on the chlorthalidone and indapamide bandwagon, and I've kind of moved away from that to an extent with some of the more recent studies. So there was a really nice article that came out that actually compared in the New England Journal of Medicine chlorthalidone versus HCTZ, and they were looking at cardiovascular risk reduction. Is there any difference? There was no difference in cardiovascular risk reduction in this study. So this one actually taught me a little bit that I don't have to have this strong preference to consider indapamide and chlorthalidone, although there's great evidence on them. One of the things that this study taught me was there's just a much higher risk of hypokalemia in the patients that are on chlorthalidone. So if you look at this study, they had about 6% of patients on chlorthalidone develop hypokalemia versus 4.5% on the HCTZ group. It was with a number needed harm of about 63. So if you treated 63 more patients on chlorthalidone than HCTZ, one more would have hypokalemia. So I often am now more recently thinking about what is the patient's baseline potassium and figuring out which agent should I recommend. When you look at the average reductions on potassium when using these various thiazides, it's usually on the order of 0.1 to 0.2 reduction on HTTZ on average. For chlorthalidone, it tends to be about 0.3 to 0.4 potassium lowering. Indapamide, it's kind of in the middle when you think about hypokalemia risk. I will note that the CLIC trial, so Dr. Lyons had this on one of her slides on chlorthalidone. This was a really interesting study, also in New England Journal. I think that came out in 2021. But this was a cool one that kind of dispelled the myth that you can't use thiazides in folks with stage 4 CKD. You still saw benefit of using chlorthalidone in that study. So that has kind of gotten me away from always excluding and not recommending a thiazide with more advanced kidney disease. It might have benefit and it will reduce proteinuria. All right, so things that I would generally speaking prefer is long half-life ARBs with combination regimens. So there's a lot of options out there. I'm not saying these are the only things, but the ones that I tend to recommend, olmesartan, telmisartan, these are two of the longer half-life ARBs, and they also have a lot of great combinations with thiazides and with amlodipine. Valsartan's got a little bit shorter half-life. Losartan, you could throw that in there too, but a little bit shorter half-life, and you might have to do it twice a day. These are generally speaking the ones that I will recommend. I do like this new Witaplic. It might not be well covered on many insurance formularies, but it actually has telmisartan with amlodipine and indapamide. This was approved a year or two ago, so it might be something that you have to actually work through various people's insurances to get approved, but it's got a lot of great combination agents within it. A couple of unique issues to highlight. Has anybody seen sprue-like enteropathy on olmesartan? Has anybody experienced that before? I've seen that in a handful of patients. So basically, patients having chronic diarrhea, they're on olmesartan, they go and get worked up by a gastroenterologist, they go and do a colonoscopy, and they have this finding of severe sprue-like enteropathy. It's almost always associated in the literature with people on olmesartan. It is very rare overall. So it's not a huge concern that I have, but I do like to highlight that as something potentially to look at. Telmisartan, one of the challenges on it, it's very hydroscopic, so it takes up water. And if you put it in many pill packs, that might actually reduce its effectiveness. So that is one medicine that from a stability standpoint, you often need it in a blister pack. And it's not as easy to combine with some agents unless it's in one of these kind of dual or triple combos. Valsartan, I will recommend valsartan. I often personally recommend it twice a day because the half-life is about 12 hours. I don't often go to valsartan though unless it's in one of the combos like Entresto where you're trying to work with people with heart failure. I think the other thing that, and Dr. Lyons did a good job of highlighting this, maybe a niche too is in losartan. It does have a unique effect of increasing uric acid output and reducing the risk of gout. So that is kind of a unique niche for it, but I will note that it might increase kidney stones that are related to urate crystals. So that's one thing to potentially watch out for. All right, going to jump in with our first patient case. So similar to Dr. Lyons, this is all real patients that I have seen personally. So 68-year-old male presented with preserved EF heart failure, 58% on an EF when an echo is done, persistent dyspnea on exertion, bilateral lower extremity edema. They were taking their medicines. They have OSA, type 2 diabetes. They were non-adherent with CPAP. They were having stage 2 CKD, preserved EF heart failure. These are their meds. When you look at their vitals physical exam, blood pressure was 162/88. slightly elevated BMI. They had bilateral pitting edema to the mid-shin, JVP, but the lung exam was clear. Potassium, serum creatinine weren't too bad. Did have an elevated BNP, but other laboratory findings and physical exam findings were within normal limits. So just shout it out. What would you do with this person to work on their blood pressure? Okay, potentially change the ACE to an ARB, maybe go up on the dose. So we're working with lisinopril 20, so I would push to the max dose of an ARB. What else? Okay, Bumex might be better option than furosemide. Longer acting agent might work for their heart failure to reduce volume. What else? Add an SGLT2. This is one of the things that I want to bring out with this case. SGLT2, and it does have blood pressure benefits. Usually about 3 to 5 blood pressure points. It'll help with the heart failure. It'll help with the CKD. It may or may not help a ton with diabetes control. It does decline with more advanced CKD. But I would definitely recommend an SGLT2 for this case. What else? Another thing that I would personally push for would be spironolactone. Spironolactone would have really good data in the context of a preserved EF heart failure patient. So I do think that you need to do the baseline things, right? So we got to check, is the blood pressure really accurately measured? What can we do to improve their CPAP adherence? I would note you potentially can get away with some combo meds or switch to ARBs to maybe improve adherence. I think Benicar would be a good option. I think Micardis would be a good option with telmisartan. Those are both combinations with HETZ that you could combine for this person. I would prioritize putting them on dapagliflozin, Farxiga. I would prioritize putting them on spironolactone. And then I do like that earlier point from Dr. Lyons. Maybe we go with the better blood pressure agent with carvedilol. That might have a little bit more effect when you think about its dual role as a beta blocker, but also an alpha blocker. So these are just a couple of things to think about. And I didn't put in the thing on Bumex, but I do think that that could be a really good option as well. Questions or things before we move on? Yeah?
You had multiple things that you would like to change.
Oh, yeah.
In what order? and when would you bring them?
That's a great point, right? Because we're working in primary care where you can't do this laundry list of things, right? So I do think that prioritizing combo meds would be a good thing. That's going to improve the compliance, and it might be just a lateral change and not actually an escalation. The things that I would prioritize for this would be spironolactone and dapagliflozin. Those would be the things that I would try to do now. You might make argument, should you go down on the spironolactone dose to 2.5? I think that you could potentially get away with just starting straight at 25 milligrams with as elevated as the blood pressure is. Then I would think about all the other stuff. Yeah, that's a great point. And that's probably a theme from a lot of these cases. I will put the laundry list of everything that you could potentially do, but the thing I want you all to take away is do a couple of things, make it easy for the patient, and do this with time. It's not an emergency to kind of correct this person's blood pressure. Yeah, Dr. Woodfill. What's that? I think finerenone is an option here. So it does have some data with heart failure. It does have good data with diabetic kidney disease, and that would be one of its labeled indications. I think that's very reasonable to think about, but I don't definitively have head-to-head data versus spironolactone. I think if this person's potassium was at a higher value, I would really push to finerenone. The other thing that might push me to finerenone would be they're a male patient, right? So you're going to have more of the gynecomastia. Might be a reason I would pick eplerenone, might be a reason I would pick finerenone. I think the one challenge with Finerenone, it does have less data in preserved VF heart failure, does have only the labeled indication for diabetic kidney disease. So if they didn't have diabetes, there would be less evidence of its benefit. But I have recommended it a handful of times off-label, even in folks without diabetes. All right, I'm going to keep moving. This is one thing I want you all to take away. Look for compelling indications. Preserve VF heart failure. Really prioritize spironolactone, eplerenone, potentially finerenone, and an SGLT2. These are going to be things that help blood pressure, help progression of the disease, and potentially even improve mortality. And then in each of these other categories, I've labeled the medicines that have better secondary event reduction based upon evidence-based medicine trials. So I'm going to keep moving though because there are a lot of cases and I want to get to a couple other things. Here's my hot take number one, diltiazem. I think it is an underused antihypertensive. One thing that I would like to note is it does have additive effects on amlodipine. So sometimes people or systems, like when you're putting it in as a drug-drug interaction, it might flag they've got 2 calcium channel blockers. Reasonable to still do. It works differently than amlodipine. Amlodipine works more on the precapillary vascular beds. Diltiazem works both on heart rate, precapillary beds, and postcapillary beds. So there's going to be less edema. An interesting thing, if you can't be on an ACE and ARB for whatever reason, because of its effect on postcapillary beds, it actually dilates the efferent arteriole and protects the kidney. One of the things that is a pet peeve of mine is masking hypoglycemia. Masking hypoglycemia for a patient with beta blocker. That's not going to happen as much with diltiazem. Beta blockers can also cause hyperglycemia, so that's another thing and reason why I like to use diltiazem. Better too with asthma COPD than a beta blocker. It's not going to affect exercise tolerance as much. The times to really reevaluate and not use in really severe cardiac conditions, post-MI, reduced DF heart failure patients, people that have bad drug interactions or bad constipation. Those would be the main things that I would caution about diltiazem. And I would note, if you're having to do diltiazem on top of beta blocker, much higher risk for bradyarrhythmias and heart block. So those are a couple of the things that I would note, but I do think that it is at times underused in people with resistant hypertension. All right, so this is our second case. So this patient is a 65-year-old person that has a history of resistant hypertension, is admitted to the hospital, blood pressure 180/120, past medical history, stage 2 CKD, diabetes, hypertension, current meds, losartan, it's maxed out, amlodipine maxed out, HTTZ 25, claims to be adherent on this regimen. Lab workup is normal. They do have severe hypertension, but they do not have a hypertensive emergency. So of these 3 options, what would you all go with? A, I'm seeing mostly. Some people would go C. So one thing that I would note with this one, this is kind of a newer recommendation from ACC/AHA. It comes at the bottom here. Escalating people without a hypertensive emergency in a non-cardiac patient might not be the greatest idea. So personally, what I would do for this individual, I would probably do spironolactone as an add-on. I would probably do option A. The rationale behind this is they've actually done a handful of non-randomized controlled studies where we have escalated and then discharged people, and they've looked at cardiovascular risk and outcomes long-term. And by doing really intense things inpatient and really escalating the regimen in non-cardiac patients, it doesn't seem to improve outcomes. What it does is it increases side effects, increases the risk of AKI, increases hypotension. So this is a newer recommendation. I think an appropriate workup is important in this person. Do they have an elevated aldosterone level? But largely speaking, I would try to do combo meds. I would keep them on their oral medicines, and I would resist our own anxiety around this number of 180 over 120. I think largely speaking, if we have worked up the patient and there is no hypertensive emergency, there is not a strong reason to get really, really aggressive with lowering their blood pressure. We are treating our own anxiety as providers as opposed to actually treating the patient in front of us. So in this situation, I'd kind of go through all those things and try to, one of the things that I do on an inpatient now with these patients is like, whoa, slow the brakes. You just added amlodipine to this patient. It's going to take 48, 72 hours to really get their blood pressure controlled or start to work. Or the thing that I see on inpatient all the time is you will make a change and you expect the immediate result the next day. And then the next day we'll say, okay, it's not controlled, we'll make another change. The next day we do the same thing, and I am trying to pump the brakes. And I'm often saying, let's make thoughtful changes one at a time, try to avoid the IV, but work them up appropriately to make sure you don't have an emergency. If you have an emergency, nicardipine. Nicardipine is going to be what we need to go to. They need to go to ICU, they need to get on a drip, and we need to figure things out. What's kind of causing this? All right, so this was a newer one that's kind of been developing, and it's now within the guidelines that we actually can cause harm if we get super, super aggressive because of the increased risk of ischemia while inpatient and overcorrection long-term as an outpatient. All right, so this is a patient I saw in residency, 64-year-old female, blood pressure of 180 over 110. Heart rate was normal, hypertension, type 2 diabetes, stage 3 CKD. She had OSA, she had obesity, hyperlipidemia, and COPD. She was not super adherent to medicine. Sadly, she had gambling addiction, so she was often resource limited from a finance standpoint. She was a former smoker, but had quit more recently. You've got her labs here. Potassium's a hair high. A1C's not super great. These are the meds that she's on. She's on an SGLT2, she's on Lantus, she's on HETZ, lisinopril, carvedilol, amlodipine, ibuprofen. I teased into that. She was using that every day or every other day. So what would you all do to kind of work with this patient? Ibuprofen, yeah. That's my number one intervention on this person, right? So it's going to increase blood pressure. It's going to be harmful for her heart, for her kidneys. And one thing that I like to note is it's going to reduce the effectiveness of a lot of medicines. So what medicines are reduced in effectiveness when you're using oral NSAIDs? Does anybody know this? ACE-ARB are going to be reduced. Beta blockers are going to be reduced effectiveness. Thiazides are reduced of effectiveness. So a lot of the things that she is actively on. The one class of medicine that stays a little bit more effective if you have to use oral NSAIDs are calcium channel blockers. So there's less effective reducing its effectiveness. But that's my number one intervention. Stop the ibuprofen. Put her on acetaminophen, put her on topical diclofenac. What else? What else should we do for this person? Okay. She was an African-American patient. What are we going to do? Increase her beta blocker. I think that's fair. We could go to the 25 twice a day. Her heart rate's not super low. One thing that I would try to figure out is how really adherent is she on all of this, right? Is she actually filling things in pharmacies? This is one of the things that we had her bring back her actual pill bottles to figure out like how frequently was she using all of this stuff and did pill counts. What else could we do? Switch an ACE to a long-acting ARB, so that's one thing. Going combo therapies. Anything else? Yeah, I mean, poor compliance and adherence is important, right? So it's going to be something that we need to, I call it the come to God talk. We got to figure out how can we get her to consistently get this regimen. Are there social determinants of health parameters that we can improve? Are there cost barriers? This is somebody that we tried to set up with our free medication program through our clinic. So that was a lot of things that we tried to do. The other thing that I think is a more important thing to do, all of the lifestyle changes that Dr. Lyons noted, the social factors from this particular case, the adherence, and then the things that I mentioned. We talked about getting off the ibuprofen. We talked about triple medicines. These were not the ones that I did at the time because I didn't have access to some of these 10 years ago when I was in residency. The other things that I would think about, to Dr. Woodfield's point, maybe finerenone could be a really good option. She's got diabetic kidney disease. She has a higher blood potassium, so finerenone might be an option. I also find this as a new recommendation from ACCHA. They are more talking about in individuals that have long-standing hyperkalemia, consider a potassium blocker. Some of your agents like Kayexalate, Lokelma, Veltessa, it's not unreasonable to prescribe these to lower blood potassium. When you think about things like Lokelma, on average it'll reduce blood potassium about 0.5 to 1 milliequivalent per liter. So actually fairly good at being able to get people on ACEs, on ARBs, on spironolactone or other MRAs. The other things that I would note is get off the insulin, try to do a GLP-1. That's going to be really helpful from cardiometabolic disease and the kidney disease. So these would just be a couple of things that I would think through otherwise for this particular case. All right, any questions before we move on? How are we doing on time? Okay, good. So a couple things that I'd emphasize to consider: CKD with albuminuria, ACE-ARB, the max amount of proteinuria reduction happens at max dose. You want to really definitely try to get to the moderate dose of ACE-ARB, if not the max dose. I think diltiazem is a great option. I think finerenone, SGLT2 are good options. Those would be all things that have really good evidence. But I've noted all the other things: AFib, angina, CVA, risk reduction, diabetes, what have you, as far as the things to, generally speaking, prioritize based on evidence-based medicine trials. All right, here's my hot take number 2, amiloride. So this was a new one for me. This came out in JAMA last year, I think in like May. This was an interesting study where it technically wasn't in folks with CKD. They had about 20-30% had diabetes. A very small percentage of patients had heart failure, but they were all resistant hypertension individuals. Amiloride had really good reduction in blood pressure, which I personally, it had fallen off my radar since I had graduated pharmacy school. But one of the nice things is it might have a hair lower risk of, even though it works as a potassium sparing diuretic, it might have a lower risk of hyperkalemia than spironolactone. There's less evidence of it as far as the definitely CKD, definitely heart failure, less evidence in diabetes, but this was a new study that I think I would be aware of as amiloride. Maybe it's used at times, and there are combination agents with amiloride and things like HETZ. So something to think about as an option in folks with resistant hypertension. And on average with this study, they showed about a 15-point lowering systolic blood pressure with both amiloride, spironolactone, not statistically different between the two. All right, so case number 4 here. So 62-year-old male, history of resistant hypertension. Medications include lisinopril, amlodipine, chlorthalidone, spironolactone. Despite adherence, blood pressure remains elevated, 155/95. Heart rate is 84. BMI is elevated at 32. Type 2 diabetes, chronic kidney disease, stage 3. His ACR is a little elevated, so he's got stage 2 albuminuria. What would you do for this person? What was that? Farxiga. Yeah. I think definitely important to emphasize SGLT2 here for risk of progression. What else? Yeah, so we're already treating with spironolactone if they do have primary hyperaldosterone. Could complicate too the workup if we were trying to look into that. We could do combo meds, right? So that might help adherence. I think this is sometimes where we get stuck a lot. We've already got on 4 things, we're doing a lot, but we're pretty far from our goal. Things that I have seen done for this type of patient, I have seen people put them on beta blockers. I've seen people put them on things like diltiazem, thinking alpha-2 agonists with things like clonidine. An interesting thing I want to introduce people to is Trevio. Has anybody seen this? Aprocitentan? Has anybody tried this or heard about it? This was approved almost 2 years ago in March. Trevio is a different endothelial blocker. So I'll show you the pathway here a little bit in a second, but it actually works on aldosterone through different mechanisms. So it's a dual blocker of endothelial receptors A and B. So it's an interesting thing. It does cause really potent vasodilation. It's approved for resistant hypertension. I thought it could be something that you could consider in this type of patient. Blood pressure lowering on average was 15 points systolic blood pressure reduction, which is very similar to things like the spironolactone options from those studies. It has a little bit different side effect profile, which is sometimes favorable, sometimes not. It does have a couple severe adverse drug reactions, but something that I think then, generally speaking, is pretty well tolerated. Has anybody seen Lataris for pulmonary artery hypertension? That is its cousin. So that is something that is lung-specific endothelial blocker. With aprocitentan, this actually works both on the lung, the ETA and ETB receptors. And if you look at this pathway, so this has an effect on our angiotensin receptor blockers, aldosterone release, and water and sodium retention. So on a different pathway, it's a new novel thing to kind of target. I have not admittedly seen this really long-term in patient populations. I've recommended it 2 or 3 times. There are a ton of issues with getting it affordable for patients because it's not super well covered on insurances. But I know there are a handful of patients that you see on a daily basis that you are trying to go through all of the issues and you just can't get their blood pressure controlled. This might be a novel mechanism that we haven't used previously. The dose is 12.5. It's done daily. It has a fairly long half-life, which is nice. I've organized this as a steps review. So looking at safety, looking at tolerability, looking at effectiveness, price, and simplicity. The biggest limitation on this is price. The price for just the drug is over $700 when you look at things like GoodRx. I've too looked at commercial insurances. This is a snapshot of locally what we see in Charleston for commercial insurers. It's not well covered by Medicare yet. This has doubled though as far as the number of insurers that cover this in the last year. So it's not covered by almost 60% of plans, but this is improving. The safety is pretty good on this new agent. So adverse effects, mainly peripheral edema and fluid retention. So some of these patients were started on things like loop diuretics. It also might cause tachycardia, reflex tachycardia. So having a rate-limiting calcium channel blocker like diltiazem or a beta blocker might not be unreasonable. The issues, it does have a pretty intense REMS protocol. So because it works through the renin-angiotensin and aldosterone system, there is the potential for pregnancy issues. So you actually have to get a baseline pregnancy test, prove that the patient's not pregnant. So there are a couple of hoops to jump through in females of childbearing age if they're not on a good anticontraceptive regimen. It also can cause hepatotoxicity rarely and a decrease in hemoglobin, but generally speaking, those didn't lead to a ton of discontinuations on it. So again, the blood pressure reduction is pretty significant. You can dose it with or without food. I still think that it's probably something that is 3 to 5 years away from what we are regularly doing in primary care. This is going to be a specialty medicine probably when we are referring to cardiology, nephrology, or a hypertension specialist. But I think with time, this does have potential to be a new mechanism once we learn more and we can kind of figure out the cost and affordability challenges with it. 6 minutes, okay. We'll do, which case do I want to do? Yeah, we'll do this. Resistant hypertension, person is 62 years old, has lisinopril, amlodipine, chlorthalidone, spironolactone. Oh no, I went back. Okay, these are the other things that I wanted. Oh, okay. No, here we go. Besides Trevio, these are the other things that I think commonly we'll do for many of these patients. Carvedilol, I like guanfacine personally over clonidine, renal denervation, hydralazine. I see probably hydralazine more than any other thing for this particular case, but I absolutely hate it. It should be 3 or 4 times a day often unless they have renal insufficiency. Yeah, question?
So in this situation, if patients have a history of heart failure and their GFR is down and they're on 2 diuretics, I mean, do you think about, are you over-diuresing them and that's stressing your kidneys at any point?
Yeah, I do think that that is nice to look at. They are on a couple of different diuretics. One of the nice things, though, with both spironolactone and chlorthalidone is it might have some short-term diuresis, but it's often not as potent as things like loop diuretics. So I do think that you do need to be mindful and watch your volume status and look at your electrolytes really closely for this person. But largely speaking, you can use these and it isn't too bad. But yeah, these are the things that I thought about as other options for this particular case. A couple other things I want to highlight. Coreg, I think this is an underdone thing in primary care, using Coreg's extended release. So that's a once-a-day version of carvedilol. I've highlighted here on the left is commercial insurers. How well is it covered? It's covered by 3/4 of plans with no issues with prior authorization or anything like that. It's less covered on Medicare plans for Coreg CR. So some of those patients, you might have to do the twice-a-day immediate release Coreg, but it is on a handful of patients. You might be able to do it. I've compared and contrasted on the right here, IR versus ER. 3.125 is equivalent to 10 of the extended release Coreg. I think this is a nice strategy to improve adherence. provided you can kind of afford it. But it's something that I would have in the back of your mind as something that we might be doing more and more kind of moving forward. And then this is my last hot take. So never use oral clonidine. Just do not do it. There's no reason to do it. So my preference, if you have to turn to an alpha-2 agonist, is guanfacine. Guanfacine has a much longer half-life. It's got a half-life more than 24 hours. Clonidine, it should be done twice or 3 times a day. Much more high risk for having rebound hypertension. Much lower risk of that with guanfacine. Also, it's similarly effective when you look at it. And guanfacine, when it has been looked at head-to-head to clonidine, it's better tolerated. You should still dose it at bedtime. You can start 1 milligram, titrate to 2, and then max out there. The only time that I personally recommend clonidine is in topical form, where you're trying to go with a different route, maybe adherence and taking oral pills is a challenge. You would also note with clonidine, it has the data in ADHD. With guanfacine, folks with sometimes we'll use the alpha-2 agonist for folks that are withdrawing from certain substances. You could also do that with guanfacine. So personally, I don't have a use that I can think of for clonidine that I can't use guanfacine for. So that's my last hot take, and I'll take questions. Yes?
Probably a question, but when I was way back in the residency, for me, we didn't have the same number of medications, obviously, for blood pressure, but we did have patients that had blood pressure that we couldn't control with everything we had. And I remember this one case where this patient was on absolutely everything, and nobody knew what to do. And some brilliant physician said, well, why don't we try a little bit of Elavil? And it was so dramatic that I think that maybe needs to be studied, because from practical, it's sort of like an antidote, but
yeah.
It worked so well.
I think that speaks to a lot when you're thinking about when we have people that have undertreated depression, and is that a mechanism of why they are not potentially taking some of the things that we're doing, and we're getting better mental health control overall?
I don't know. I don't think it was that. I think it's that those original antidepressants did have a lot of powerful lowering blood pressure effects, but I defer to you guys to figure out whether it's worth a try.
Very good. Other?
It's time. If anyone wants to stay and talk with Scott, I'm sure he's quite happy to. But
yes.
Please fill out your attestation, put the hours and your name, and then also use the QR code to give us an evaluation. You can leave the attestation at the desk on your way out if you don't want to have to fax it to Kara.
Thanks, everybody.
And thanks
I'll
for
stick
coming.
around.